today's talk, we're just going to focus primarily, just do a really broad strokes overview of brain tumors. So I'm one of the brain tumor specialists here. That's all that I do, covering the whole, spectrum of intrinsic, intraaxial, extraaxial brain tumors, skull-based tumors. So we'll go through those. So I'll go ahead and share my screen. So no matter what you guys go into, you can see the screen okay? Perfect. So no matter what you guys go into, you will face a day where you meet a patient with a newly diagnosed brain tumor. And I think it's really helpful to be able to form a framework in your mind of like, how do you think about these tumors? Where are they? What do we do for them? And I think just the first thing is to be able to kind of see like, hey, is this a tumor that came from the brain? Is this a tumor that's growing from the covering of the brain? Or is this a tumor that came from somewhere else and spread to the brain? So just that kind of simple question already narrows down kind of your differential diagnosis. It already kind of narrows down like what are the options for treatment, what the natural history is of these lesions. So the first thing I generally think about is like, did this tumor come from the brain or is it coming from somewhere else? And we call that intraaxial or extraaxial. We think of intraaxial tumors like a glioma, whereas extraaxial would be things like a meningioma, so growing from the meninges. It's also helpful to talk about, where they're growing from, so where they're located. So is it above the tentorium, so supratentorial, or is it below the tentorium or infratentorial? And that can also kind of help guide, like, your thoughts in terms of like, a pediatric patient is more likely to have an infratentorial tumor, whereas adult patients are more likely to have a supratentorial tumor. So all of those things just go into your thinking as you're kind of building your framework about what's going on. So, whenever you're at all concerned about a possible brain tumor, it's always, important to ask about certain risk factors and kind of think about, patient age, patient sex, patient, symptoms, signs, all those things. And so, think about, patients that have a risk for cancer or have had cancer in the past. So, has a patient ever had breast cancer or lung cancer and they're presenting with worsening headaches? That should kind of cause alarm bells to start ringing to go looking for something. Um, Describe the headaches. Are they worse in the morning? Are they worse in the evening? Kind of positional changes. Are they worse after laying down when you're sitting up? When you're doing your physical exam, you can look for things like papilledema. Do the patients have nausea, especially when they're laying flat? Have they had a seizure? Do they have weakness in any extremities? So their arms, legs, any cranial neuropathies. So a lot of these things you can detect on your physical exam, and then that can guide, where you go imaging to find what's there. So in terms of the imaging for brain tumors, what I'll say is that a CT scan is generally a really good screening exam. Kind of gives you a 10,000-foot view. You can see things like edema. You can see if there's a mass lesion present, but it doesn't give you the full picture. And so, kind of start there. But then in terms of next steps, I would say if you're at all concerned, patients deserve an MRI of the brain with and without contrast. So that's kind of our gold standard. And then if you do find a tumor there, it's usually beneficial to image the rest of their body, just to determine if there's any other sites of primary disease. So I will ask you guys for a little audience participation. It's all fun. We're all learning again. So let's just say we see a tumor on a brain MRI that we're concerned about a metastasis. How about Ryan? What percentage of patients will we never find the primary tumor, at least on imaging?
I mean, I think it's just a guess, but I would say maybe like 25%.
Yeah, it's a good guess. It's higher than you think it would be, right? Like it actually ends up being up to 40% of people. You don't see a primary tumor, even if you take the tumor out and you're like, hey, this is a metastasis. Like, where's the primary tumor, you kind of have to wait for pathology to kind of give you clues about that. So the body imaging is not perfect, but it can at least identify other sites of disease that can help guide your decision to pursue treatment or not. So especially for everyone on the call, if you diagnose a new brain tumor, or you find a new brain tumor, or someone talks to you on your team about a new brain tumor, you have to let an oncologist or a neurosurgeon know. It's not enough to like, oh, I'll just put the referral into Epic and it'll magically happen, right? Like you need to speak with someone, on the treatment teams just to make sure that these patients get timely, therapy. And I think that's true as you go along in your training for just about anything. Like if you identify a GI bleed, or if you identify, a tumor elsewhere, like actually speak to the people that would be, treating these issues out of professional courtesy and to make sure that no messaging gets dropped in the care of these patients. So just kind of going down. So if you identify a brain tumor, what's the most common thing it's going to be, Regina?
Is it a meningioma?
It's not a meningioma. I'll give you a hint. It's on the screen right now.
Oh. Oh boy. Is it the melanoma?
Metastasis, just metastasis.
Oh, just metastasis. Okay.
Yeah, so that's the most common type of intracranial tumor is a metastasis. So like whenever you put together your differential, like, hey, there's a brain tumor, just always put metastasis on that list and you'll never be wrong. That is the most common type of brain tumor that we see. How about the most common type of primary brain tumor, Jory?
That now I feel like maybe something more like something benign, like a meningioma, as opposed to something neoplastic, like a astrocytoma or glioma or something like that.
Yeah, so yeah, you're right. So a glioma would be the most common intrinsic tumor that we see. And so for metastases, they tend to be at the gray-white junction. There can be one, there can be multiple. The decision of how to treat, whether it's via surgical approach, radiosurgical approach, really depends on the patient's functional status, where the tumors are located, how many there are, and whether or not, they can be treated by any other means. So it's a complex decision that's well beyond the scope of this, but just know that pretty much any patient that has a brain tumor goes through a multidisciplinary discussion with neurosurgery, radiation oncology to kind of make sure that we're providing the best care for these folks. So to your point, Jory, primary brain tumors, right? Most common ones are gliomas. Does anyone know how many grades of gliomas there are? Matthew, maybe?
This is a total guess, but like 4.
Yeah, 4. So which one's the most benign? Which one's the most aggressive?
1's the most benign, 4 the most aggressive.
Good. Can you think of an example of a grade 4?
GBM.
Yeah, exactly right. So glioblastoma. So that's the most common primary brain tumor in adults. How about Ashlyn, the natural history of a GBM? We know it's aggressive, right? It's a grade 4 tumor. What is median survival of a glioblastoma with maximal treatment?
I think it's somewhere around 18 months.
Yeah, not far off. So 14.6 months is the median survival for glioblastoma. And what's the treatment that you say we identify a glioblastoma? Who else hasn't contributed yet? We'll go back to Ryan. What do we do for these folks, or at least try to do when we identify a high-grade glioma?
Yeah, I don't know the specific regimens, but I know they're typically not operable, right? And so I would imagine it's some combination of radiation and or chemo.
So it just depends. Most of them we do try and do surgery on. And the reason for that is that we have really good data to suggest that the more tumor we take out, the better people do. You are exactly right that we cannot take out all of it, right? Because we know that these tumors have already sent little tentacles throughout the brain that we can't see on MRI. So let's just, for instance, Regina, let's just say we see a patient with a right frontal glioblastoma. And let's just say for fun, we did a complete right-sided hemispherectomy. So all the right side of the brain is gone. Or did we cure them of their GBM?
No.
Okay. Where's it going to come back?
Was in the right front, potentially in the left side.
Yeah, the left side,
maybe.
it'll come back. And we know that because people have done that. A long time ago, people have done complete hemispherectomies for high-grade gliomas, and the patients recur on the other side. And so it's an aggressive tumor that's already spread throughout the brain by the time, we get to them. Ryan, you're exactly right. Some form of radiation and chemotherapy, right? That form of chemotherapy is temozolomide. In the early 2000s, they published their study on the benefits of temozolomide in addition to surgery and radiation. Ashlyn, how much longer do folks survive when they get Temodar, as opposed to just surgery and radiation?
I feel like it's not that much of like 6 to 12 months, maybe.
6 to 12 weeks.
Oh, oh.
So when they get chemotherapy, that's how much it extends life. So another drug that is FDA approved, but for recurrent glioblastoma, is Avastin. You guys may have heard of it. It is a VEGF inhibitor, and it's approved for recurrent GBM. So, Jory, how much longer does it extend life compared to just doing surgery?
Maybe by like a month or two. So maybe, or I guess better than the other ones, maybe like 3 months, but I feel like still maybe not a great outcome.
Okay. How about Matthew? I'll frame it like this. Does it give you days, weeks, months, or years?
I'm gonna swing for the fences and say years.
I like your optimism. Cool. How about Ashlyn?
I'll just say weeks.
Okay. It's nothing. It doesn't prolong life at all. So this $100,000 drug, why is it FDA approved if you don't get a single day of survival benefit from it? Any guesses?
Does it improve quality of life?
Yeah, to your point, it's it can decrease the need for steroids, and so kind of decreases the edema associated with it. But it's pretty crazy, right? So this is like the most aggressive type of cancer you can think of, that no matter what we throw at it, it will continue to grow despite what we throw at it. So very aggressive tumor. You wouldn't wish it on your worst enemy, but we're trying to make advances with it every day. So grade 1 through 4, grade 1 tumors we typically see in kids. So pilocytic astrocytomas, kind of a much rosier picture, that, folks get surgery and then oftentimes they don't require any kind of chemotherapy or radiation for many, many, many years. And so much rosier picture than the higher grade tumors. Other types of tumors, so meningiomas, right? So these are tumors that grow from the meninges. They often get their blood supply from the meningeal arteries. These are very, very common. I would be willing to bet that one of us on this call has one. Just take us like bonking our heads and getting a CT scan in the ER, and they're like, oh, we found a little 1 centimeter meningioma. And that's fine, right? We just follow those and, it's no problem. When they grow and cause significant mass effect or swelling within the brain, that's when we want to start thinking about treatment. And in general, depending on where they are, surgery is the first line therapy for them. Radiation also works very, very well for small kind of asymptomatic lesions. You can kind of treat prophylactically. But in general, we don't treat with radiation until we see, growth of these lesions. Otherwise, other tumors that are especially near and dear to my heart are pituitary tumors, so pituitary adenomas. Who's going into ENT again? All right, awesome, Ryan. We're going to do a bunch of these cases together. So that also means that I get to ask you the first questions about it. So are these benign? Are these cancerous?
Typically benign.
Yeah, typically benign. So we think of pituitary adenomas, right? There can be functional tumors and non-functional tumors. So, Regina, what's the difference between those?
Functional tumor would increase kind of the patient would be symptomatic.
All right, so functional tumors secrete a hormone, and
Mhm.
non-functional tumors don't secrete a hormone.
Do not.
So, in general, treatment for functional tumors, you're a little bit more aggressive on just because there can be a lot of side effects from having too much of any one hormone. So, Jory, when you have too much growth hormone, what syndrome does that cause?
Acromegaly.
Acromegaly, right? And then how about Matthew, when you have, too much ACTH being secreted by a functional pituitary adenoma, what does that cause?
I actually do not remember.
Okay. How about Ashlyn?
I'm not
Regina?
sure for either.
How about Regina?
I missed sorry, what was the
When
secret?
a tumor secretes too much ACTH, what syndrome does that cause?
It's Cushing's?
Yeah, Cushing's disease. Awesome. So what's the difference since you're on you get to keep going. So what's the difference between Cushing's disease and Cushing's syndrome?
Cushing's syndrome is where patient has like increasing intracranial pressure and you have it, correct me if I'm wrong, you have bradycardia and
Yeah, you're thinking of a reflex.
oh, that's Cushing's.
but-
Okay.
Yeah, how about Cushing's syndrome though?
Can I phone a friend?
Yeah, phone a friend. You get to call on the next one.
Brian.
I'm pretty sure Cushing's syndrome is the collection of symptoms associated with Cushing's disease, but Cushing's disease is the actual increase in cortisol.
Yeah, good. Almost there. You're on the right track. So Cushing's syndrome is the syndrome of steroid excess, right? So that could be from injecting yourself with steroids. It could be from, whatever, having too much steroids and the downstream effects of it. Cushing's disease is just Cushing's syndrome from a pituitary source. Cool. Good. And so when we see a pituitary tumor, our workup for it generally involves a multidisciplinary team. For non-functional tumors, our indications for surgery are generally size. So, greater than a centimeter or compression of the optic chiasm. And so, who are our internal medicine folks again? Good. All right. So, Jory, you see a patient with concern for a pituitary tumor. What blood tests are you going to send?
So I think if they have symptoms that are concerning, like hopefully if I have brain imaging, I've seen it, but if not, I would get imaging to look for a tumor there and then probably start with like a CT and then also send off like a prolactin, probably maybe cortisol, an IGF and a growth hormone, an ACTH. And then I guess you could also check thyroid, but I think that's pretty rare.
No, you nailed it. Yeah, those are the kind of the heavy hitters. So, what is IGF? Like, why'd you say that?
I remember it's like insulin growth factor 1, but it can be reflective of growth hormone, and I think it's maybe a little bit more. I I don't remember exactly why it differs, but growth hormone can like differ with different changing states, whereas IGF I think is a little bit more concrete, maybe with less immune to changes in the homeostasis of the body. But I
Yeah,
don't
no,
remember.
good. I mean, that's really good. So you're exactly right. Like I think of IGF-1 as like the HbA1c for growth hormone. So it kind of gives you like a 2 or 3 month like average of what the growth hormone is. And so that tells you like, do they have too much growth hormone? Whereas growth hormone, right, kind of fluctuates throughout the day. So you may just catch it at like a very high point or a very low point. And so that IGF-1 gives you that average value. So good. Now, how about Ashlyn? So actually, I'm going to take that back. How about Ryan? So of those blood tests, let's just say the lab's down and they're like, you know, Dr. Carlson, you only get to send one blood test. Which one of those are you going to send?
The prolactin,
Why?
because that's the most common pituitary adenoma is a prolactinoma.
Okay, but you're right for the prolactin, but what does that what difference does that make
What difference does it make knowing
in
what
terms
that
of your
is?
decision making? Like, hey, this tumor secretes prolactin or it doesn't.
I'm not sure what you're asking. I think feel like decision to do surgery is probably more so a size consideration rather than how active it is, I guess.
Yeah, so Jory looked like she was raising her hand.
Yeah, I think we have medications, right? Because it's
Yeah.
sensitive.
So
You
you
can give
yeah, you can treat prolactinomas without surgery. And so if you check the prolactin and you know it's a 1 centimeter tumor and the prolactin's like 500, then you can just give them a pill, right? Cabergoline, and they don't even need surgery. So it kind of puts you down a different treatment pathway compared to other tumor types. Now, there's also going to be cases where you guys are in the emergency room on your intern rotations, and a patient is going to come in with an acute onset of headache, blurry vision, nausea, vomiting. Has anyone ever heard of that with a newly identified pituitary tumor? Has anyone heard of that before? Something called pituitary apoplexy. Have you guys heard of that? Yeah, so when that happens, that's an emergency. And so you guys are going to be the front lines next year to take care of these patients. And so when someone comes into your ER bay, they get a CT scan, they've got a hemorrhagic tumor. You're guys going to be like super enterprising, you know, interns. You're going to send away all the blood tests, right? And the patient's going to be feeling really crummy. And so the blood tests will start to come back and they're going to say, hey, the patient's thyroid is low, and patient's cortisol is low. And so, Matthew, what are you going to do? I think you're muted. Sorry.
Do you do like an early morning cortisol?
You could, but let's just say it's 4 o'clock in the morning and we got the cortisol and it's really low, like almost under.
Then would you go right to head imaging or like
Yeah,
get
so
a
you get an image and they've got a big hemorrhagic pituitary tumor. But they're like, Dr. Thomas, man, I feel really sick.
um could you just give them steroids in that situation?
Yeah, absolutely. Um, one of the interns that you're on with wasn't on our lecture today, and they're like, Matthew, should we also replete the thyroid hormone while we're at it?
Um I would say no, because thyroid hormone's pretty unstable and when you're acutely ill.
So yeah, no, you're exactly right. You do not want to treat with thyroid. So want to be very clear when you guys take care of a patient with pituitary apoplexy, you want to replete their steroids, right? Because they may have adrenal insufficiency. Now, what happens if you give thyroid levothyroxine without replacing their steroids? How about Jory?
I guess just thinking more like theoretically about how the axis works. If you're increasing the function of the thyroid, but you're not giving them the tools they need to like keep their blood pressure up and do all the things that like they should be doing.
Yeah,
But
that's
steroids don't
exactly
give any
right.
backup to cortisol,
That's
then that can
exactly
be
right.
catastrophic.
Yeah, so you can precipitate an adrenal crisis. And that's not something that you can fix with like pressors or fluids or something, right? So always make sure, give steroids. You don't need to give thyroid. Like it can wait, right? Like that can wait 5 days until you've treated with steroids. So just something to be mindful of, that when a patient comes in with pituitary apoplexy, draw the labs and frankly, just give them steroids, right? Don't even wait for them to come back. But what you don't want to do is give them thyroid. And so that's just something to remember. Otherwise, other types of tumors, so, skull-based tumors, things like vestibular schwannomas. Again, you probably know people with, something like this, whether it be a family member, friend, aunt, uncle. These are super common. We generally offer surgery once they're quite large and pressing on the brainstem. But in general, these can be very safely watched for a long, long time. There is a whole plethora of other tumors. Each of these deserve their own volume to go over. But just know that many other types of tumors exist. If you see them and you're at all concerned, or it's a new diagnosis, call a neurosurgeon or call an oncologist to make sure that we get them worked up in the care they need. But otherwise, that's all I had. Just 30 minutes, kind of quick and easy today. Unless anyone has any questions, I'll plan to see you guys around the ORs.
I do have a quick question.
Yeah.
So my understanding is like metastases and GBM look relatively similar on imaging. But is that correct? Like, is there any way to distinguish them, or is it mostly like tissue pathology?
That's a great question. They can look similar. I would say, like when you make your differential, you're always like, oh, this is a GBM, this is metastasis, this is tumefactive MS, this is lymphoma. It's kind of the same four things that technically it could be. I would say there's enough imaging characteristics that you can kind of differentiate them most of the time. But there are certainly cases where you're like, I'm really not sure here. Yeah, good question though.